All right, let's get right into it. When you picture a surgery, you're probably thinking about the surgeons, the scalpels, maybe the anesthesia. But what about that simple IV bag hanging by the patient's side? Well, here's the thing. Managing a patient's fluids during an operation is one of the most critical and delicate balancing acts in all of medicine. It's a high-stakes tightrope walk where one timing misstep can change everything.
And that is the heart of the matter. On one side of that tightrope, you've got hypovolemia, not enough fluid. This can literally starve vital organs, especially the kidneys, of the blood they need to function. But on the other side, you have hypervolemia, way too much fluid. This can completely overwhelm the system, causing that fluid to leak into the lungs, a complication that is incredibly dangerous.
So, how in the world do clinicians stay on that tightrope? That's exactly what we're going to break down. We'll look at the fundamental challenge, the different tools they have in their toolkit, and what happens when that balance tips. Then we'll dive into the modern tech that's like a safety net and see how it all comes together in some of the most complex surgeries you can imagine. So, what's the actual goal here? At its core, it's all about maintaining what's called organ perfusion, making sure every single part of the body gets a steady supply of oxygen-rich blood. Think of the heart as a pump. The goal is to get the most bang for your buck with each squeeze, what doctors call stroke volume, without flooding the whole system. And wow, this really shows you how much our thinking has evolved. For years, the standard approach was based on these rigid formulas and this idea of a third space, this kind of hypothetical ghost compartment where fluid was thought to leak during surgery. So the thinking was, we have to replace it aggressively. But as it turns out, modern evidence suggests this whole third space idea is probably a myth. So today, the approach is totally different. It's dynamic, it's personalized, and it's guided by real-time data. It's a strategy we now call goal-directed therapy. Now, to manage this delicate balance, you need the right tools. And in this case, the most basic, most essential tools are the different types of intravenous fluids themselves. You see, not all IV bags are created equal, and choosing the right fluid is a huge part of the overall strategy. Broadly speaking, IV fluids fall into two big categories. First, you've got crystalloids. Think of these as simple, water-based solutions with tiny little molecules like salt. Because they're so small, they don't just stay in the blood vessels, they spread out all over the body. Then you have colloids. These have much larger molecules, like the protein albumin. And the whole point of these bigger molecules is to keep the fluid right where you want it, inside the bloodstream, for a longer period of time. But, and this is a big but, even just within that first category, crystalloids, there's a huge ongoing debate. On one side, you have normal saline. It's cheap, it's everywhere. But it's packed with chloride, which can cause something called metabolic acidosis, and has been linked to kidney problems. On the other side are balanced solutions, which are designed to be much more like our own body's plasma. And when you look at the big studies, the evidence is all over the place. The SMART trial found a benefit for balanced fluids, but two other huge trials, Plus and Basics, found no real difference. It's a perfect example of just how tricky these decisions can be. We've talked about the challenge, but what actually happens when that balance is lost? Let's raise the stakes a bit and look at one of the most feared complications of fluid overload, especially when we're talking about chest surgery. This is acute lung injury, or ALI. It's a really devastating condition where the lungs basically fill up with fluid, not from the outside, but from the inside, leaking right out of the blood vessels. And research has shown over and over again that giving too much fluid during surgery is a major risk factor for this happening. And the numbers show just how bad this can be. In patients having lung surgery, up to 1 in 7 of them can develop ALI. But look at that second bar, the mortality. Once ALI sets in, the chance of survival just plummets, with some studies showing fatality rates as high as 64%. This isn't just a minor setback, it's a catastrophic failure of that fluid balancing act. So what's actually going on a microscopic level? Well, the problem often starts with damage to this incredibly delicate structure called the endothelial glycocalyx layer, or EGL. It's this super thin, web-like lining inside all of our blood vessels that acts as a barrier. Fluid overload, hypervolemia, can literally damage this layer and cause it to break apart. This is especially true with crystalloids. Once that barrier is gone, the vessels become leaky and fluid just pours into the surrounding tissues, like the lungs. Okay, so we've seen the problem and we've seen the dangers, but the good news is that we've moved way beyond simple guesswork. So let's look at the modern tools that give clinicians a precise, guided approach to walking this tightrope. This is the million-dollar question for every single anesthesiologist, right? It's not enough to know about too much or too little. You need a reliable signal, something that tells you, hey, this patient's body will actually use this fluid effectively. How do you get that signal? Well, the answer lies in shifting from static to dynamic monitoring. For decades, we relied on static things like central venous pressure or CVP. It gives you a single number, like a single photograph of a flowing river. The problem? Study after study has shown it's a terrible predictor of whether a patient actually needs fluid. The modern approach uses dynamic parameters, which are way, way smarter. They actually use the patient's own breathing cycle as a built-in diagnostic test. You see, every time a ventilator gives a breath, it gently squeezes the heart and vessels. By measuring the tiny variations in blood flow with each breath, things like stroke volume variation, clinicians can accurately predict if the heart will respond positively to more fluid. And here's how that works in practice. This is a basic goal-directed fluid therapy, or GDFT, algorithm. You're constantly watching a dynamic parameter like SVV. If it stays high, say over 13%, that's a signal the patient needs fluid. So you give a small, measured amount, a fluid challenge. Then, and this is the key part, you reevaluate. Did the SVV number go down? Did the blood pressure get better? If yes, awesome. If not, then you know more fluid isn't the answer, and it's time to think about using medications called vasopressors instead. It's this constant cycle: assess, intervene, and reassess. Now, these principles are the foundation, but of course, they have to be adapted for different situations. Let's take a look at how this tightrope walk gets even more complex in some of the most high-stakes surgeries there are. This table lays it out perfectly. For a lung resection surgery, the absolute biggest fear is acute lung injury. The remaining lung is incredibly vulnerable, so the evidence points strongly towards a restrictive strategy. You limit the total fluids. But in a liver transplant, the challenges are totally different. You've got these huge fluid shifts, and the kidneys are at high risk. So here, the guidelines suggest a moderately restrictive strategy, using vasopressors to keep the blood pressure up. And notice that crucial point: avoid certain synthetic colloids, because they've been linked to kidney injury in these specific patients. At the end of the day, all of this points to a massive cultural shift in surgical care. We have moved away from a blunt, one-size-fits-all approach to something that is so much smarter, so much more personalized. It's a huge piece of the larger puzzle we call enhanced recovery after surgery, or ERAS protocols, which is all about optimizing every single detail to get patients better, faster. And that really leaves us with a final thought to chew on. As the surgeries we perform get more and more complex, could it be that our ability to master this one seemingly simple thing, that IV drip, and our ability to walk this incredibly fine tightrope of fluid balance might just be the ultimate key to unlocking a better, faster recovery for everyone?